Good evening, everyone. It's great to see all of you here, all of y'all. If you haven't mastered that yet, please try. It's how we say friendly things in Texas, where I'm from. So welcome y'all to this evening's symposium. First I want to thank Edwards for sponsoring this symposium on tricuspid valve disease. We've had a lot of tricuspid stuff here at CVI this year, and we're going to continue on that theme, which is an incredibly important topic that I think is going to be something that we need to address for the remainder of my career, at least. So I had the pleasure of moderating this first part of the symposium, and this part is going to be about the problem of TR, and I can't think of a better person to kick it off than my good friend and colleague, Dr. Maurice Sarano, who has been an incredible advocate with regards to the public health crisis of valvular heart disease, and he's going to give us his perspective on TR. Maurice?
I need the, where is the command?
Oh, clicker.
The clicker. Clicker. Clicker, okay. I had a glass of wine, so I don't know. Don't trust everything I say, huh? Okay, so this is the view of the tricuspid. And so if you want to look at a public health crisis, it has to be something that is frequent in the population, that is deadly, and that is not well served. So if you have a disease that is rare, it can be a public health crisis. If you have a deadly that is not serious, it cannot be a health crisis. And if we know how to treat, like pneumonia, then it's okay. So here is my case, because everybody starts with a case of a woman who had no murmur and had heart failure. And we were discussing how heart failure of tricuspid regurgitation is different from mitral regurgitation, but it was clearly linked to tricuspid regurgitation here. So the first question is TR frequent? You know, the only epidemiology in the classical epidemiology world was the work in Framingham about tricuspid regurgitation, but if you look at the numbers of people who were studied, was very small, and no real conclusion can be made from that. So we got interested in the community to have enough patients to look at the people diagnosed in the community with tricuspid regurgitation. It's the green line here, that tricuspid, and that's every other left-sided valve disease. And if you look at the numbers, you're unimpressed because it's like 0.6% of the population. But it is predominant in the older population. And if you look at the prevalence by Oxvalve study, which was doing systematic echoes in people who are older, 65 and older, you can see that the prevalence is very similar in the 65-74, and is a little higher because they are diagnosing by systematic echo people who were undiagnosed. And now if we look at the next one, which is the recently published data from New Ulm by my colleague Mario Gossel, you can see that the number that we have is very close. It's one number, 6.2% of TR in the 65 and above, in people who are not previously diagnosed with valve disease. So there is a signal that in the older population, there are a lot of people with TR who are undiagnosed, but in the younger population, we have less people, and the diagnosis and prevalent disease is the same. But using these numbers, you know, you have to adapt. This is the pyramid of population in 1921, and 1 century later, humanity has completely changed. with a much more older population. So I'm looking for a curve that will be like this, you know, very wide, but a much older population. Having a disease in the older population here meant nothing, and now it's meaning everything, the disease in the older population. So if you calculate using the diagnosed population, not the undiagnosed disease, it's 1.6 million people in the US with moderate or severe tricuspid regurgitation, but we have to take into account the rate of mortality in the patients with tricuspid regurgitation, and mortality is the pink one, and you see that it's between 10 and 15% overall in every type of regurgitation per year. So it means that the incidence in the US of new TR cases diagnosed per year, diagnosed, not those that appear and are undiagnosed, is around 200,000 per year of new cases of moderate or severe TR. So it is clearly frequent, but is it deadly? Is it really something important that we need to pay attention to? And everybody knows this paper from NATH saying, okay, if you have TR, more TR is more mortality. But in that study, what happened is that with TR, a lot of things changed, like the age of the patients, like the EF was lower, like the RV was worse, and they could not adjust for everything, including pulmonary pressure and comorbidity, because they didn't have those measurements. They didn't have the measurement of the symptoms. So it's very difficult to make any conclusion. Is TR an associated disease to everything else, or is TR responsible for the mortality of the patients? So when we looked in the community, the problem is that TR is very heterogeneous. You have left valvular heart disease, half of the patients, and then pulmonary hypertension, LV dysfunction, and a distribution of other causes. And the age is advanced, but not in all patients, mostly predominant in women, and with a high frequency of atrial fibrillation. But that heterogeneity means that we have to analyze the prognosis by clinical context. We can't say, oh, TR in general, because otherwise we ignore the factors that are determining the mortality in that specific subgroup. So analyze in specific clinical context, and if we look at LV dysfunction, HFrEF, what do we see? Well, we see that TR is associated with a mortality which is considerable. So 0, trivial, mild, moderate, severe. You see that enormous increase in mortality. And it is true whether you have right ventricular dysfunction or no right ventricular dysfunction, pulmonary hypertension or no pulmonary hypertension. So it is true in every type of situation that TR has an impact on mortality. Degenerative MR, where we have, there is TR, and TR in this case is associated with high mortality overall, mostly under medical management, but persisting even after treatment by surgery of the mitral valve disease. So there is, again, an enormous separation of survival curves that persist even after treatment of the left-sided valve disease. And then finally, the patient with isolated tricuspid regurgitation, what we call now atrial functional tricuspid regurgitation, where the RV is okay, where the LV is okay, where there is no valve disease, and even in those cases, you have an excess mortality associated with severe tricuspid regurgitation. So even if you have, independently of context, of EF, of pulmonary hypertension, TR is associated with increasing mortality, with increasing TR severity. So it appears that intrinsically TR is associated with a high mortality. Now, I want you to curb your enthusiasm because we have to understand the part that is due to something else and the part that is due to the TR itself. And in fact, you see in HFrEF, the hazard ratio associated with severe TR univariately is 2.7, and it goes to 2.1 when you adjust for age and sex, and 1.6 when you adjust for age and sex and a lot of things, hemodynamic abnormalities that are associated with the HFrEF. So there is a considerable decline of the risk as compared to those survival curves that I've shown you, because TR is not isolated, comes with lower EF, comes with different things. And so, but 60% is pretty significant in terms of mortality, but we have to be careful that we don't translate those survival curves immediately into risk. And if we look at FTR in patients with DMR, you see that the hazard ratio univariate goes from 8 to 9 to around 2 related to the presence of severe TR. So when we do the calculation to do a clinical trial, we shouldn't use the 8 and those enormous separation in the survival curve, but these hazard ratio to appropriately calculate the sample size of what we're going to be testing in the improvement in outcome by treating TR. So that's an important thing. So TR is deadly, clearly defined, but is it an unmet need for treatment? And it is clearly. In the US, 1.6 million people, and we do less than 8,000 surgeries per year. If we look at the patient diagnosed in the community, and it's not any community, it's Olmsted County, which is the community around Mayo Clinic. If you have severe, moderate, or severe TR, your chance of having surgery, tricuspid surgery in your lifetime, not 1 year, not 2 years, in your lifetime is 2.4%. So in that specific county where we're supposed to be treated up to standards, 2.4% are ever operated. And that's the same in HFrEF, but here we're not surprised, 4% at 5 years are treated by surgery. And the most striking is functional TR in patients with DMR. It's the most surgical disease that we know. It's impacting survival, but you can see that the number of people treated is extremely low. Even as we have a surgical disease, TR is ignored in those patients when they are treated. So a lot of these TR are undertreated, and this is a fact that is absolute. So in summary, TR is frequent. It's a deadly condition. It's an unmet need for treatment because it's severely undertreated, and we need to do something for it, and we need to have better and more consistent therapy. Thank you so much.
Thank you, Maurice. Some of those mortality calculations would have been really helpful a few years ago. Questions for Dr. Sarano? Comments, anyone? Yeah.
I think, again, fantastic talk. I learned so much from the studies you have done. But so TR is bad, but what it doesn't tell us is when to treat. And, we get these slides shown all the time, only 8,000 surgeries, etc. But we don't see these patients. So we see these patients to us maybe a real end, and then, of course, the mortality, everything is going to bad. So in your studies, did you find a trigger or a point where it's a tipping point or a zone where you should start treating them sooner? And currently we see patients who are really fit, who probably don't need anything, and then we see patients at the other end of the spectrum.
Yeah, it's so little studied. Do we have biomarkers that are telling you that you need to operate on the patient? How do we measure right ventricular dysfunction to discourage or encourage treatment? We don't have that. How do we measure heart failure? In Triluminate, it's a big thing. How do we measure heart failure in patients with tricuspid regurgitation to assess those patients? We don't have that. So we have not said when it's better. There was so little attention. The paper of Nina Brownwald in, what was it, 63 or 66, where she said, don't pay attention to TR. it had so much impact. It was imprinted in the brain of everybody to say, don't pay attention to TR. And now we're at the phase where we're dispelling this paper to say, pay attention to TR, but we haven't gathered the specific risk markers to say, oh, let's be more aggressive. So we're in that phase where the young investigators have to find the right marker.
But when we criticize that paper, but that was rheumatic heart disease, a completely different population, young people where remodeling is common.
Oh,
but now there's a huge shift. We see them all 90 years old.
Yeah.
And it's a very different disease.
Yeah, peace to Nina Brunwald. It's just that what we have learned is don't pay attention to the right side, pay attention to the left side. And I think we need to pay attention to the right side and to be much more alert. When you say, okay, in the place where I worked, between 2.5 and 5% of people are operated ever during their lifetime, it's kind of a very low number. Yeah. So now I'm sort of shouting, pay attention, but I don't know to what.
Maurice, one question I have for you. Given how successful we are with treating left-sided disease, with coronary disease, and good medical therapy, do you think the prevalence is going to rise because patients are living longer with HFpEF, AFib, hypertension, those things? Do you think, because the prevalence numbers you show are pretty low, even though it's a large unaddressable market, but do you think that prevalence is going to change as we get better with managing other disease?
If we do detection in a more thorough way of the tricuspid, we're going to find more cases. And that's what the study of Mario in New Ulm and what the Oxfam says. The older patients, they have a lot of TR that is completely ignored, undiagnosed, and we need to pay attention to that. And we're going to find cases of people who have atrial fibrillation 10 years. They think everything is atrial fibrillation, but the TR is responsible for their heart failure.
Along the same lines, Maurice, I mean, do you think we should have a stronger and closer partnership with our AP colleagues? Because there's a fib that comes back and back. Let's do another third, fourth ablation, right? And the pacing leads as well. I mean, this patient population is right there. I mean, and we don't come to see them. I mean,
see, he's much younger than me, and he is full of hope. He is full of hope that you can talk to people in EP. The problem is that there's no conversation.
Our one EP faculty has already left town, unfortunately, so she decided to get on a plane 20 minutes ago. So sorry, Dr. Nair, wherever you went. Yes, Sheesh.
Dr. Sarano, you published the functional MR data that had different cutoffs than what we have now and showed mortality was high. The right-sided pressures are lower. We are applying the same parameters to diagnose moderate, severe, torrential TR. I think, as you showed on your slides, moderate TR also has higher mortality, but maybe moderate is not moderate on the TR side.
Yep.
I think the whole paradigm has to change, that we're waiting for severe and torrential. I think that's another part of it.
That's a very good point. We have changed the scale on the very severe to invent new words so that it serves the clinical trials. But what we have not paid attention is to redefine the lower part of the curve where we need to pay attention and to be more aware and to say, oh, this guy has this measure and we need to pay attention to that. And so, and we know also that valve disease in women is less treated. So how will we mark severity in men, women, and what's the measure that is the right measure for those? That's a very important work to be done. Very important.
Perfect. Thank you, Maurice. It's fantastic. Well, along the lines of massive torrential and tsunami TR, we have the one who's probably said those words more than anyone else in the past 3 years, Dr. Hamid. Why is imaging the tricuspid valve so hard?
Thank you so much, Paul. And to Maurice and Vinny's points as well, I think part of the issue of late detection is we echo community have been underestimating, right, Dr. Sarano, of tricuspid regurgitation. And I think now with the evolution of tricuspid intervention, I think we all know it with TE imaging, it has been really challenging. These are my disclosures. And, we get all our RV inflow, outflow views, the 3D, and, there's sometimes these cases in the screening, I get so good images, and then on the table, that's how I'm feeling with my lead underneath. I'm actually sweating because I really have trouble seeing it, and I'm like, oh my God. And why is it so hard? It's because the leaflets are thin, they're variable, they have multiple segments. You heard in the last 2 days about this. And the structure of the tricuspid valve is really anterior, so you get a lot of acoustic shadowing if you have left-sided prosthesis like pomatus septum, and also any mechanical valve as well on the left side. And in addition to that, these are old patients, elderly, the esophagus path can be very difficult as well. I had several cases recently with very difficulty in passing the TE. In the TE suite, Paul and Marcus will organize the TE with my GI, and they will tell me that the path of the esophagus may be crooked in some of these patients. And so it's really hard to get on-force imaging and require lateral resolution. The challenges, you've seen this in my previous sessions, the multiple coaptation planes, which we'll talk about, torrential TR, the leaflet tips are like, fingertips, like what Paul described to me, because they are so vulnerable to stress, and that's where SLDA. So this is a case, thanks to Paul and Richard for lending it to me. You've seen it before. This is a case where it's lead impingement, horizontal heart. Look at that. This is on the table in the cath lab. Really hard to image and visualize the septal leaflet. And then in the transgastric view, this is, I think it's multiple segments. I think it's 4 leaflet, type 3B. RV inflow, outflow view is really, really hard. Paul and Richard were about to abort this case. But, I heard in my previous slides, I think I'm a true believer in ICE imaging. I think in certain cases like this, thanks to the support of all the vendors that we have throughout this symposium, really has revolutionized in terms of ICE imaging for cases like this. We can get really good images during the screening, but on the table is a different matter. I mean, it has really helped us in terms, you can see, even do 3D MPR out of this ICE catheter imaging, and also you can steer as well the TE for this case, using the TE, getting in the ballpark, and bouncing it off with ICE imaging as well. So for the tear therapy, similarly to the Pascal, using the ICE catheter imaging has really helped not only the 3D MPR orientation of the clip or class, and with precision and accuracy as well. This case as well, I think the quality of the ICE imaging, you can see that leaflet, septal leaflet interaction, that free maneuvering that Paul did on the right-hand side to get rid of the septal leaflet, and also confirming it, the leaflet insertion in the transgastric view, and looking back at ICE. So really toggling between TE and ICE. So what we do in cases, we park the TE. We don't have the privilege of having 2 consoles, so we have 1 console, parking the TE probe in the transgastric view, and the ICE imaging, as Paul will do in the right atrium, and we can get the RV inflow outflow view with the orthogonal views for leaflet insertion. And so for this case, in the transgastric view, we thought that there was caudal tethering, which reduced the ability to pull the arms to the atrium, as you can see in the pointer and the arrow. And so release of the grafts, actually you can see that the grippers were on the wrong side. So that we could not see on the TE, but you could see it on the ICE imaging. And then so did a second grasp, we were able to grasp it with the first, clip. And then on the second clip, putting it right next to it in the posteroseptal region, using both ICE and also transgastric view as well to place the second clip. But for this one, you can see that there's actually tethering of the cords in the transgastric view. And so just readjusting, regrasp, and releasing it. So really toggling between TE and ICE imaging with the final results, 3 clips, and you can see with at least moderate TR, residual TR, and of course, looking forward to the results of the trial in terms of the effects of leaving moderate residual TR in these cases, but still 2 grade reduction from torrential to moderate, and the patient quality of life was certainly improved. But the question when to pull out the ICE catheter, like I mentioned, when there's imaging challenges, contraindications to TE, really the need to confirm leaflet grafts to avoid the SLDA. You've seen this slide multiple times I presented. My big five for TEER success, I think the mnemonic, Galileo, which has helped me a lot, looking at gaps, looking at anatomy, the number of leaflets, leaflet length, mobility, the multiple coaptation planes, the leads, imaging windows from multiple windows, and of course, ICE imaging preemptly as an adjunct to TEE, and looking at other structures, the right ventricle, the pulmonary vasculature, and the left-sided disease. And before I end, I certainly think tricuspid imaging is doable. The big five: patient selection, focus on recreating and restoring coaptation, use all modalities. Like what Master Yoda said, do or do not. There is no try. With that, thank you, and may the force be with you.
Thank you, Nadira. I feel like I should call you Princess Leia. Okay, so let's talk about this a little bit though. So in practice, TR imaging is challenging. You and Richard, and I know Joao does a lot of the imaging as well. Do you guys want to talk a little bit about when these therapies become more common, the commercial rollout of TR imaging, and how we're going to train people to be imagers like you three? I mean, how is it? And I'm sorry, I don't mean to offend any other imagers here as well. They're just right in front of me. And but maybe Nadira, you could speak, and then you could just chime in.
I would first like to applaud, I think, the vendors, and there's a huge collaboration between the industry partners and also the imaging vendors as well. I think now they saw the huge need in our community beyond imagers like us, that we really need to train the community. So there's huge partnership, that's number one. In terms of training of the masses, it's gonna be very difficult because there's so few of us. And so the thing that now has really brought on is simulation. I think that can really help in terms of training this, having a lot of class, courses, and also kind of a relationship with societies. A lot of these have been ongoing, much more work to do, and I think it's certainly something that we all work together to help
Richard,
this.
you want to comment? I'm going to guess that you didn't get specific TR imaging. I mean, certainly you knew how to get a 4-chamber view, but how many imaging cases did you need before you felt you could really guide me through the procedures?
Well, I'm kind of slow, so it took me a long time, but a lot of pain. But that's part of the challenge, is that it's not easy, it's not intuitive, it's not something we learn in our fellowship. Yeah. So I think the point is, as imagers, you really need to work on the foundation of TEE imaging, not just say, well, I don't need to really learn this, I can just jump to ICE, because it's foundational and there's pain involved. But I think the simulators give you the concepts, and I think that will speed up the learning curve. But in the real world, we all get that pain, like Nadira's slide in the real world when it's really challenging. But learning little tips and tricks from each other and some sort of training sessions, I think will help speed up that learning curve. And ICE will definitely be a part of it, but I think it can't be an excuse to kind of bypass some of the TE learning curve.
Well, I just want to apologize for any pain I've caused you. Okay? It just sounds like you've really suffered. Joao?
I guess maybe it's the lead, the radiation. No, jokes aside, there has been an incredible effort, by several other folks that are here and also not here, on societies to develop documents and training. I would encourage all the interventional cardiologists to bring their imagers to meetings like that, and many others as well, because sessions like this one and dedicated sessions for hands-on, I agree, simulation based with TR cases as well. That's different than the normal anatomy. You got to train normal. I think we'll continue to improve that, and know when there are limitations, then you need to pull other adjuncts. Yeah.
Fantastic.
And I think ICE actually really cranks up the pressure on the structuralists to learn echo, MPR, it's stuff that it's not natural, and I think there is a learning curve there.
NPR, that was natural. Okay, all right, fantastic. So we'll move on along the lines of imaging. So maybe, Joao, we need less echo. CT, MRI?
So we thought that the echo was easy, right? CT and MR. So thanks, Paul, and a fantastic meeting so far. Have been tasked to talk about a little bit about CT and MR. When does it play a role in some of the disclosures relevant to this talk that we have been doing? How do I advance here? There you go. Some of the work that we're doing as a core lab for some imaging trials in tricuspid valve. So let's just debunk a myth here. When we talk about them, oh, it's too expensive. CT, we can have access. Okay, let's just look at the numbers. The numbers speak for themselves, all right? So this is 2023. This is not outdated data. CMR without gadolinium, CMR with gadolinium, T, transthoracic with GAD, without GAD. So what you see here is that, it's not a matter of cost. Let's just say that we're not doing because probably it's the access. It's difficult to get these patients there. There's some pushback, there's some organization, but it's not a matter of cost. Cardiac CT is actually, if CMR is the Walmart of cardiac imaging, I would say that CT might be actually the dollar store because it's the cheapest one. And that's why, we have been leveraging and trying to get so much out of that, and was one to show. Where does it fit and what does it add? It adds tremendously because we don't know what we don't know. And if we don't see it well, we don't image, we're going to keep trying the same result over and over. So this is a paper that we had done with Becky and a few others to show how MRI in this case and also CT can help in the right side assessment, right ventricle assessment, function volumes, quantification of tricuspid regurgitation. It's all volumetric. It's not pieces, it's not measurement. It's three-dimensional. And here comes the NPR again, Paul. As I'm rotating this crosshairs, you can see the IVC relationship, the eustachian valve, how to get to that tricuspid valve. You can see leaflets. Of course, you don't need to do this for every single patient. But if you do it, please do it and do it properly, the analysis, because that is going to provide you immense value, as well as assessment of the right side. This is by CT. The esophagus is right here, typically. Look at how am I going to image this tricuspid valve. It's going to be all slanted as a horizontal heart. So that is going to also provide you that information, that guidance. Can I get adequate images from that? The protocols are not the same as scanning TAVR. You have to trigger this in the PA or do a test bolus. If you do it properly, you can see leaflets. You can see well the right side and a little bit on the right side. And with that, you can see also physiology. You can see that this is the largest valve in the body. If I just go back one here, and look at the gaps and look at how wide this is. This is a surgical view with a coronary sinus septal anterior posterior leaflet. We can recognize, obviously, this has been done by TE, that the tricuspid valve anatomy is incredibly variable. It's not only 4 leaf, can have 5, can have 2, can have 3. But the variability is immense, and also where the pacemaker lead is, we might need to move away, like it's showing here. This pacemaker lead here is quite mobile. Are you okay to clip this patient here, Paul? On this one here, we can probably try to clip the addressable gap, which is right underneath, but it's going to create some shadowing here from the anteroseptal gap. This is the RV view, so septal, anterior, posterior, septal, anterior, posterior. We got to clip just underneath that. This one here is pushing the septal leaflet. So it gives you the insights of what is the mechanism of the TR. And by removing that lead, am I going to improve the TR? Is that a worthwhile exercise, or is that putting the patient at more risk? We can quantify the TR severity too by looking at the size of that hole using MPR, and that correlated well with 3D vena contracta area in a patient population that AFib is very common, 92% of these patients. And the bigger the hole, the worse the TR, and the worse the remodeling, as you would expect. And you can use that here in this case. You're measuring the gap similar to what you could do with the transesophageal transgastric view. You can measure the gaps and you can plan the clip. You can give the coaxial angle. And you can also understand the relationship between the IVC and the tricuspid valve. Ideally, when you come from the IVC, you should be facing the tricuspid annulus and the centroid right down the center. That's the ideal, because you're going to become completely orthogonal and clip this really nice. On the other hand, when the tricuspid annulus is distorted, the more horizontal the heart, the bigger the right atrium, you have to do not only this, but you also need to do a lateral flexion. And by doing so, you might create some asymmetry in the gaps. And that is going to create, obviously, potential for SLDA, but also create another coaptation plane that did not exist to begin with. So the complexity of the tricuspid valve when trying to address that. CT, if you do a pose and compare with the pre, you can see what happens. Even though it's an edge-to-edge repair, you actually restore this concave or convex, depending on which side you look from, but from a flat annulus to regain that shape, in addition to reducing TR and producing RV reverse remodeling. This was when we did the EFS evaluation, just a handful of patients, but to show that indirect annuloplasty occurs. Now, when you fix the TR, this is with the clip, what would you expect to happen? Obviously, you're going to reduce the tricuspid regurgitant volume. Again, by volumes, you can look into this, what happens with the right ventricular volumes. The right ventricular systolic volume does not change much, but the end diastolic reduces. So you're reducing the TR, you're going to shrink that ventricle. And more importantly, you're going to increase the effective forward flow. So the cardiac output, cardiac index increases, and that's why these patients feel better, because you're improving the forward flow. There was a question about the timing. When is the ideal time? And I think there is still a lot for us to learn, but it seems that RVEF by either 3D echo or by CMR, and I would say probably by CT, if below 45% seems to be associated with worse. Maybe it's not just as simple as an RVF, but maybe the size and the quality of their RV might be also important. The pattern of contractility, right, that longitudinal descent. The main engine for the RV is that longitudinal descent, the TAPSE that we measure. That's the longitudinal function, but you also have radial function. So when you lose both, that's the worst RV, and these patients don't do well when they're treated with TIR. This is a series from Leipzig. Or using some other quantification. This is a very recent paper from the group in Milan, looking at this index of RV to PA coupling. You have heard that TAPSE over PSP, two measurements that we can get by echo, seems to associate with better outcomes. The problem is that TAPSE only describes one motion, and PSP sometimes is relying upon getting a good TR jet and being properly aligned. So what they did here was actually look at the three-dimensional echocardiography to look at the effective forward stroke volume. So the RV, when it squeezes in the presence of TR, of course, not all the forward stroke volume goes through the pulmonary artery, but goes back into the right atrium. But if you can measure what crossed that effective, you have a better separation with this index. So that might be a better way for us to do that. So in closing, if we don't know yet who was the ideal patient population, I would argue that we need to consider the adjunct and potentially trials like what our Illuminate has done for providing some mechanistic insights into the effect of TR reduction would be important for us to understand who are these responders and non-responders and what does the response look like. Both CT and CMR can provide an incredible value. I didn't have the chance to talk about the structure of the myocardium, but that also will be important. And this great understanding will hopefully move the needle forward so that we can continue to expand future indications and improve the patient selection. So, thank you.
I'll stay there for a second, because I gotta ask, I think, a potentially provocative question here. So if
Where's my drink here?
So if CT is a dollar store, and you get incredible information from CT without spatial limitations, okay? We have to say that CT versus echo.
Yeah.
Is CT a better screening modality for TR than echo?
If I am a patient, I would say let's get the CT. Like, if you think about, TR, let's put a pause here. You talk about left atrial appendage. Why do we still do this left atrial appendage screening? Do that CT. If there is no clot, you can shock this patient. Do left atrial appendage screening. CT, I think for screening, and a lot of these patients that when I do the TE, sometimes I'm covering the TE, I say, okay, gaps are big, it doesn't look good, let's get the CT. Once the creatinine is good, let's get this patient in the CT. I think from what I have shown here, that there is an incredible value that it can provide in many ways. Whether you can clip, what are the gaps, what is the difficulty in the anatomy, and if it doesn't seem clippable, it still allows you for assessment for TTVR. So
I can say this because the echo people know how much I love them. So, and I would never say one versus the other exactly, but let's just say if there's a throughput issue.
Yeah.
If one center has an issue with getting people in for echo or getting in for CT, it's reasonable to start with CT. Is that fair?
I would think that that's totally fair, and that could provide a mechanism to. The gaps are so big, the RV is dysfunctional. It's going to be hard. And so maybe you can, optimize the patients and diaries better and try to get to a clippable stage. But that CT, which, patients come in and they don't need to be NPO, they just need to breath hold for 3 seconds and that's it. I think is a great screening tool.
Maurice, Vinny?
Do you think that the regular CT done by radiologists who are thinking about going to the beach rather than treating the patient is gonna provide the information? They're gonna pay attention to the valve. That's
Is it
the question.
scalable?
Is you can do it, and you can do with the CT, see everything, and because you are completely trained on the valve disease. But there is the rest of the world, and the rest of the world, maybe the radiologists will not pay the same attention to. And so the screening echo as a value. The problem is sometimes the screening echo doesn't even look at the right side. And we have to improve the screening echo to then give the patient in your hands for the complex analysis that you can do.
That's a much more provocative question. So hopefully no radiologists here so I am fine. Okay. All right. Tino, of course. He's true standard deviation. So, this is, so we know Tino.
And you're not at the beach right now.
Exactly.
So.
But he's in Miami. He's close, Let me put it this way. When we took the challenge to do imaging sub-study for Triluminate, there was a labor of love and continue to be, because we said, these are 10 sites that we have developed a relationship with the imagers and we have trained them. And we were learning along the way. Now we got 10 sites that can do that. Can we expand beyond that? There's 10 experienced sites. TAVR has taught us a lot about CT that is possible and how to scan. We don't need to obviously do all that I have shown you here on CT. But if at least we can look at the size of the ventricle, the dilation of the tricuspid aneurysm, maybe try to see the leaflets, that could potentially be a screening. It's the applicability of that, and I take your point. It's valid. We have to continue, and there is a document that we're working on to really do a cookbook, how to get to that, which I think it's going to amplify.
Vinny?
Good luck with the cookbook. But
Preface.
I bought 3, but I have not yet cooked a single good dish. So I'm going to ask you more provocative question now.
Oh.
Being a friend, I think I'm allowed. So I love your imagination, the slides about annuloplasty effect. And it's fascinating to me. Like, you put a clip on the leaflet and, on the mitral and tricuspid side, but you are forgetting that actually the TR reduces, RV remodels. And that's why you're seeing that artifact which you call annuloplasty. So it's nice marketing term, but actually, unless you show it, that there's an annuloplasty effect, independent of TR reduction from the pre-treatment, I think this is just observation.
Will you send me a patient without TR? I'll put a clip on.
You reduce TR or not. You reduce TR, your RV is going to reverse remodel. Every dimension is going to come down. So it's not annuloplasty. It's whatever TR reduction is there, your preload and is going down. That's all.
Yeah, I take your point, although the magnitude of that annular reduction seems to be much bigger than one would expect with that 2-grade or 1-grade reduction of TR. There is a direct effect. There is no doubt that the annulus shrinks as you approximate. Now, how much is that is from the TR reduction?
The point of Vinny is very important in that the right ventricle is so plastic that it's very misleading. We give treatment, the heart shrinks, the TR shrinks, it almost disappears, and we're reassured we don't see the patient. A year later, the patient is in full-blown heart failure, RV completely dysfunctional, and we have left the moment go, and that's related to that plasticity of the right ventricle, and we have to do the surgery or the intervention at that point where we see it, not to be falsely reassured by that improvement that we see after diuretics in saying, look, he's so improved, the TR is a trace. But it's not a trace, it's gonna come back. The wolf is around, it's gonna come back and eat you. And so we have to sort of raise the awareness that not to be reassured by the jet disappearing for a while, and by some temporary improvements. And to be very aggressive in the therapy.
That wolf comes out there in Thanksgiving salty turkey dinners is what happens. So anyway, that was great, part one. I'm going to turn it over to my good friend and colleague, Dr. Gorav Ailawadi, who's going to take the next part.
Welcome. Great, thank you. That was a great session. So we're going to shift gears instead of talking about the problem with TR and how we're going to screen for it. To make us all more aware, we're going to talk about solutions. So our first talk is from Steve Bolling. He's my partner and good friend, and he has taught us all a lot about TR. TR is bad, as he says, and he's going to talk about what surgeons know about tricuspid.
Thanks, Gorav. And I want to thank Edwards for setting up the symposium. I want to thank Paul for setting up the whole meeting and also giving me this title on a dinner symposium, Paul. You know I'm going to go wild on that. I also like to say that cardiologists are some of my best friends. Not Anita. She's being mean to me tonight. But that will not stop me from giving this talk. So things only surgeons know about TR. I know 7 things that you don't. It's actually way more than that, but we'll concentrate on 7. So TR is important. We all know that. Patients feel terrible. Patients die from TR. TR is bad. It's deadly. We know that. I like that. TR increases mortality. It's severe and moderate. So think about the word moderate TR. Bad. Again, moderate TR is bad. TR after surgery is bad. If I leave it, it's bad. And look, moderate TR is bad. Moderate TR is bad. After a clip, moderate TR is bad. So that is one thing that I know. Moderate TR is bad. Cardiologists out there kept saying like, moderate TR, nobody dies from that. Yeah, but it's terrible. It is deadly and it's bad. So moderate TR is bad. If I said to you, Paul, do you want moderate TR or no TR? Which one? Oh, they're exactly the same, aren't they? No, you want no TR. So let's get over that concept that if you leave, like if you move it from tsunamic to just hellaciously bad, you're probably not helping the patient. So that's one thing that I know. I will not leave TR in the operating room. So how does the tricuspid work? So I've heard at this meeting that the tricuspid has 3 leaflets or 7 leaflets or 14 leaflets, and by MRI it has 100 leaflets, and what? No, it works like the mitral valve. It's a bileaflet valve. It coaps together like a Roman arch. These 2 planes are what actually go against each other. That's why when I see somebody with adult Epstein's, they have 1 leaflet opposed to something else, and it works just fine. It works like a Roman arch. Once you drop that keystone in, it does fine. And that distance between the 2 legs, that A to B width, is what determines whether we have coaptation. If you don't have coaptation, you have TR. I'm a simple man from a small town in the Midwest. And it's just math. Everybody can do this. That's the size of your tricuspid annulus. That is the size, 2.8 millimeters across, very tightly held. In a population, I was a math boy, you guys all know that, everyone has an annulus between 26 and 30, everyone in this room. So when you tell me I'm going to clip it and leave the annulus at 44, that is not a good idea. If you have less than a 30 millimeter annulus, you have no TR. As soon as you're at 40, everyone's going to have TR. It's just math. And 75% of the patients who have MR have already backed their annulus out and the RV changing and changed from that ovoid to a circle, and they've uncorked their coaptation reserve. So moderate TR is bad. The tricuspid valve is a Roman arch. That's all it is. The math should work, therefore, in annular reduction. And that's why it works when we put a ring on it. If we reduce that A to B distance, you're going to reestablish normal coaptation, and of course it works. We put up Dreyfus's paper. They're really the first one to randomize it. None of these patients had severe, and you can see that 2 years later, 50% of them, if you didn't touch their tricuspid, kept on rolling, progressive TR. And if you put a ring on it, then they did fine. This is Jim Gammey's first paper, undersized, really at a 28 ring, re-normal size, brought it back down to normal. Everybody did great. This is our paper, 262 patients, everybody did great. Dave's Adams paper, 645 patients. I just showed you data on 1,000 patients who had annuloplasty and they did great. And they ended up not with like going from tsunamic to just, oh my God, bad. They actually went down to no TR. Of course, we don't believe that, so we did a randomized trial. Gorav and I were involved in this, and we hit the primary endpoint, which was not mortality, but progression of TR. Of course, it's deadly, but these people die slowly over time. And you can see that the progression of TR was 1,000% less progression of TR. That's not a misprint. It's not 100%. It's 1,000% less at 2 years if you reduce that AP diameter. And we realize that. Surgeons realize that. We have made the patient pay the ultimate price. We've put them on bypass, stop the heart. We can do anything we want. I can pour concrete into the tricuspid valve, but I put a ring on it. 95% of the time I put an annuloplasty on it, it works fine. I can do anything I want, and I choose an annuloplasty because we realize that it works like a Roman arch, and reducing that A to B distance works. So moderate TR is bad, tricuspid valve is a Roman arch, and annuloplasty, good. I'm a simple man. So what else do we know? Well, what are we doing in transcatheter tricuspid? Why not just put an annuloplasty on? Anything that I can do with surgery, Jason can do with a catheter, I bet. Not really. And so we've tried it. Cardioband, millipede, takes 17 hours, and it's very difficult, blah, blah, blah. No. Okay, does every catheter device have to recapitulate surgery? No, it doesn't. Does stenting look like what I do at bypass surgery? It does not. So it doesn't have to, and we should take advantage of what we can do with a catheter for the patient, not just recapitulate surgery. So we've tried things like almost an annuloplasty with Trialign, and you can see they left a 10 square centimeter annular area. That's a size of a tricuspid valve I can almost put my head through. And of course, this is what it is. So it doesn't have to look like surgery, but it has to have the same biologic effect. Yes, it does. How about some other things, like tricuspid spacers? Great idea, easy, but it didn't work. So it doesn't have to look like surgery, but it has to have the biologic effect. What about the Triluminate trial? So if you look at this, 50% of the patients at the end had moderate or severe or worse TR. Okay, so that's not a great outcome. Now, everybody in this room says, but it was safe, but it was safe, but it was so safe. We have to get over that in catheter world. We'll give you it's safe. You know, patting the patient on the head and say, oh, take some Lasix. That's safe too, but it doesn't help them either. So, and if you look at it, I was a math boy in college, and this drives me insane. An FS waterfall wind cascade, you don't win on the first one, you don't win on the second one, you don't win on the third one, you don't win on the fourth one. I'm okay if they all point the same direction, but they didn't. And if you look at it, what we won on that is just KCCQ, which is a subjective, patient-aware form that they fill out. And it was all driven by the 25% of the patients who actually had their TR reduced. So from this trial, we can say if you get rid of TR, the patients feel better. Well, I think we knew that before this $1 trial. So there's no mortality improvement. Heart failure actually went the wrong way. There was no 6-minute walk test change. KCCQ only if you had 2 grade less TR. Is that a positive trial? Well, it is mathematically, but we have to be very careful with that. And you know that this was done by the best people in the world. Actually, Paul did 94% of the cases. So in the real world, this is not perfect. They claim success, but if you look down there in the little box, it's because they only moved it by 1 grade. So they could have moved it from tsunamic to just massively terrible, and they left severe, at least severe in all of them. So it's not perfect in the real world. So we have to be very careful. So as a surgeon, here's what I know about percutaneous TV repair right now. I go, things that make you go, We are not very good at this. We're not helping patients as much as we think. Well, what about replacement? So, well, we can't do that annular thing, Steve, so let's just replace it. That is not how we would think in surgery at all. That is not what we do in surgery. We know that a repair is going to be better than a replacement. Also, these things are all upside-down TAVRs. Who sat in an office and said, hey, I have a different idea. It's an upside-down TAVR. Why do we always have to have everything an upside-down TAVR? Yeah. And they're all mitral rejects, like, hey, it didn't work in the mitral position. Let's stick it in, what's that other valve with the blue blood? Yeah, we'll do that. And they're all way, way, way too big. That's the size of my mitral annus. If you tell me, well, we need a bigger one. We need a 62 millimeter blah, 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 blah device. That is that big. No thanks. So surgeons also, when it comes to replacement, we know where the AV valve is because we can take a look at it and we see it there and we try to avoid it. We don't always, but we try to avoid it. And you know, if you put a round thing in there and expand it in all directions at once, you're going to squish the AV node. I know that. You should know it too. This is how we tell our fellows, 10 stitches from 10 o'clock to 6 o'clock. Stay away from that end of the clock. Don't put any pressure on it. So what about the replacement devices out there? Well, they have a huge screen fail rate. They have a periprocedural mortality. They do have a pacemaker rate associated. But the worst thing we have is RV non-recovery. That's because what we're putting in there is something the size of a Diet Coke. Everybody take your fist and squeeze it as hard as you can, just like that. Squeeze, 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 squeeze. Okay, now what I want you to do is take 2 fingers and stick it out, so pin the top 2 fingers, and then just squeeze with the third and fourth finger. You cannot squeeze it hard. That's what we do when we pin the annulus down in the RV. So, percutaneous TV replacement, I think the status of what I know as a surgeon right now is, oh boy. I would never put a 54 device into somebody if I operate on their tricuspid valve. Okay, I can look and see the tricuspid valve, and we're beamed over the head as surgeons to say exposure, exposure, exposure. You can't see it, you can't fix it. I think that middle screen is either one of our imagers trying to look at the tricuspid or me driving in the snow to work in Ann Arbor. I'm not sure, but they're about equal. And Jason says he buys his imager for tricuspid things. He buys them compression stockings and a back brace because it's going to take hours to do them there. You got to be able to see it. And I think we have to switch over to ice, ice, baby. There's no doubt about it. We just have to get it, or we're not going to be able to do tricuspid. I know that. So you got to see it. And then the last thing, and this is probably the most important thing, is that severe TR is probably too late. You're already cooked at severe TR. The RV is fried, it won't come back, and so on like that. This is a great study, 3,000 patients who were operated on, and this is a landmark study, so the operative mortality is out. They don't do any better because they're already fried. And this is also something, it's too late. Okay, grade 1 through 4, but then you had to pick, where's Becky? Okay, so she's not here, good. So you had to make new grades so you could look at your clinical trials and reset, but it had nothing to do, and it's not validated in patients. If you move them from torrential to massive, do they do any better? Okay, fine, there's that one study that shows they have 100% mortality with torrential and 99.9% mortality with massive. That's fantastic. If we continue to do catheter cases on patients like this with 1 foot in the grave and 1 foot on the banana peel, it's not going to work, and we're never going to show that any of these technologies are going to work. It's the parable of the parachute. You take patients and you throw them out of a plane with a parachute, and without a parachute people do a lot better. Okay, parachutes are good. Another study, throw them out of a parachute, put the parachute on wrong, tell them you can't pull it until 5 feet above the ground, smack, they hit, everybody dies. From this study, we think parachutes are no good. We're all very confused. Parachutes are good. So good therapy applied too late just doesn't work. If you pull the parachute 5 feet above the ground, you're going to assume that parachutes don't work. If I jump out of a plane, I won't. But if I do, I want a parachute. So do it early. However, the thing that I know most importantly is this. We're going to continue to do this. We're going to iterate. We're going to innovate in this field. We have to because of this reason. Oh, no, this is a $10 billion market. No, that's not it. It's this. There is a huge unmet clinical need. There are massive amounts of patients. I know that. I see them in clinic all the time. Thanks very much.
Oh, this is good. So any questions for surgeons? This is your time, and you can get back to Steve
Go well.
too. But so Steve, you simplified some things about the tricuspid valve and said that a annuloplasty is really going to fix a lot of it. But you and I know that not every tricuspid valve has the same pathophysiology. There's a lot of tethering in some of these patients. So maybe you can tell us a little bit more about how often do you see that with what we think of as moderate or severe, and then when you really get to this massive torrential, how much is there additional forces that are causing the TR?
Yeah, so the better question is asking, why are you seeing the patient at that time? So if we had a device that we felt comfortable with doing that was effective before the patient, the horses are out of the barn. You and I can put a patch in there, do an annuloplasty. Those are the patients that I replace anyways. But if you think of it, who knows how many tricuspid valve replacements are done in the United States per year by surgeons? Anybody else? 800. That's exactly right. 800. That's it. There's 340 million of us. All of us have TR. We do 800. 800. And if you think of it, there's 4,000 cardiac surgeons, so the average guy does one every 5 years. So we really do not replace the valve very much. I don't want to see that patient. Yes, there are patients like that. Yes, we have to start down the line. And yes, we have to do things like that. And we will have to replace a few of those. But if we had a device that we really were consistently happy with, we would start to put it in upstream. That's what I think.
I love the way you present things because it simplifies.
I'm a simple man from a small town.
And the issue is that the tricuspid repair, we know that between 25% to 40% have recurrent TR. And so while we would love to indicate annuloplasty in everybody, it has proven that it's not really a solution for a lot of patients. And so how do we deal with this impossible thing that we're referring too late and we have a high operative mortality? When we do the repair, there is often a recurrent TR, and we're in a big conundrum.
So I think that's a good question. There's a lot of things going on. The average number of tricuspid repairs per year per surgeon in the United States is 0.8, less than 1. So surgeons are not comfortable doing it. The second thing is when we see a patient who is so dilated like that and has tethering downward, those patients should probably not be repaired and replaced. But if I'm doing something once every 17 months, I probably am not doing it very well. The other thing, I think because we're not comfortable at it, I've heard this all the time, saying somebody said, I repaired the mitral valve, Steve, and then I tried to repair the tricuspid and I put a 36 ring on the tricuspid and I came off a TR or it recurred. And that person says to me, I don't think you can repair the tricuspid valve. And I tell them, I agree with you. I don't think you can repair the tricuspid valve. Because you'll never get tricuspid stenosis by putting a normal size ring on it. It's never been reported. So I think why manufacturers make a 38 tricuspid ring, that doesn't make any sense to me whatsoever. So I think it's our uncomfortableness with doing that because we're just not very frequent at doing it.
I think just added to that, you're absolutely right, is why people make, manufacturers 6 different rings which go from wherever to wherever. But I think the main question is just annuloplasty, like on the left side. Undersized annuloplasty didn't work that long if you had tethering. So I think we need a bit more objective parameters in understanding this undersized tricuspid annuloplasty, and that's why we see recurrence. We also saw in your series, which you showed, multiple series that mean, is that independent of pulmonary hypertension, etc. So if you treat the left side, but pulmonary hypertension continues, the RV is still going to suffer and dilate, and so the annuloplasty will work for some time, but will not work after some time. And I think we need probably something additional in future as well.
Well, it's not a surgical meeting, so I'm going to say what we really need is a catheter device because we all feel more comfortable putting a catheter device further upstream in the patient because the impact on them is much less. I'll give you that. So I think we need to think completely differently than try to recapitulate surgery and think of a catheter device that can change the annulus. And then if something happens, yes, it's tethered or yes, it continues to change. Remember, the LV will continue to change from ischemic disease. The RV really is not affected in the same way as LV, and it's not entirely analogous. Let's think differently about catheter devices that can go in earlier and perhaps be converted, some kind of system.
You made a comment on triluminate, and I'm asking this question to you and to Paul. Are we measuring heart failure for tricuspid regurgitation the right way? Because hospitalization for heart failure may not apply to people with tricuspid regurgitation, and maybe that's why we didn't see that much improvement. So what do you guys think?
Short answer, because that's what Dr. Cohen's going to talk about.
Yeah.
I'll answer in 2 seconds. You have to ask yourself, what is a patient with TR come to the hospital with? They come for the need for IV diuresis, and we looked really hard to define that, and it was hard, and we had to go by traditional left-sided definitions, and it is what it is, and it turned out to be not that high for these patients.
But it was interesting to me that, if you think a wind cascade, if it all goes the same direction, you're pretty happy with it too. But that actually went the opposite way, and I think that probably was a definition problem. But the fact that the cascade reversed.
Well, the issue with this is that, COVID, the Triluminate was during COVID. 90% of the patients were enrolled during COVID. Hospitalization rates across the United States dropped for all types of cardiac disorders during COVID. Whether that kept people away or whether there was a bias in terms of device. So in other words, if you had a device and you had an issue, would that bring you back to the hospital more likely?
Sure.
We don't know these things, and we'll never know. And so I think it's really hard to know about those trends. So I wouldn't read much into them, is what I would say.
And I'm not blasting the Triluminate, I'm glad it was positive, and let's move forward.
Well, a lot of things to discuss about new devices. So perfect segue. Vinny's going to talk about transcatheter tricuspid valve replacement. Nice try. We're talking about solutions now. So you're going to tell us how to fix it.
Since Steve has already set the stage that these are Pepsi cans, I think I'm going to show you some Pepsi cans. And I don't work for either Coke or Pepsi, so I think it's safe. So I think there's a lot going on. I think one message I really want to give the community is that there is always this slide is shown that how surgery hasn't built good evidence, but I think you have to remember that the cardiologists are the ones who don't refer us the patient. So I think the evidence building hasn't happened not because there was no interest, but it just doesn't work. So we have seen these pictures many times. I think for every device, we have to go back to basics. And it's pretty interesting that I strongly believe there are 3 leaflets, but then I kept arguing with Joao that you see many. So I went to Gray's Anatomy, and actually in Gray's Anatomy it says very clearly that there could be 3 to 9 leaflets. So I believe Gray's Anatomy more than anyone. But technically speaking, there are 3 functional leaflets. It's a new term. And all these things are important if you want to undertake any procedure. But what is also critical, not so critical in replacement, is the right coronary artery. But right coronary artery tends to give a good landmark for tricuspid annulus in majority of the patients. But the AV node is important because if you're putting that Coke can in, which is based on oversizing, there's going to be a high rate of pacemaker. We have also seen a case where a very oversized valve in very early experience has eroded into the aorta as well. So I think there is a lot happening in that area. And with time, we have learned that we need 0 to 2% oversizing and not traditional 5 to 10% oversizing in tricuspid. Sometimes you have right coronary artery. If you're lucky, there is a stent in it. And if you're really lucky, it's calcified. So it really gives you good landmarks. But again, applied anatomy is really important for TTVR. We always talk of devices, but we never talk of delivery systems. Now, success of every device is based on delivery system. And in tricuspid replacement, of course, what access, what is the trajectory, and we have already learned a lot that why did the mitral systems didn't work in tricuspid. And I think the good example is the MitraClip. You needed to change the delivery system and not the device for the tricuspid. So I think both are equally important. The TTVR landscape is ever changing. These are less devices than the TMVR devices when we started. That used to fill 2 slides. And you can see that there are many concepts. But when you see this patient, who is a 92-year-old patient from Colombia, re-op, and this patient had this fantastic result, and she was on the dance floor at 1 month, I think you start believing that this therapy is not futile. Although in some patients, but definitely we need to understand which patients? We have already learned that when the tricuspid dilates, it becomes flat, and actually it plays in the hand of TTVR, because as we know, flatter the annulus, easy is to position the valve. So in fact, this becomes a favorable attribute of dilated right ventricle. Anchoring and sealing mechanisms are very different. This is just a flavor of 3 devices. Some are on anterior leaflet and RVOT, some are just on the leaflets, and there are some devices which go around the cords like Navigate and Evoke or EOS, and also use the oversizing algorithm on the annulus. RV shape, we always thought that good, there's no LVOT obstruction. You know that in TMVR, the 80% or 60% screen fails are because of LVOT. But here, the problem is the depth of the RV. The depth of the RV, when you measure it perpendicular to the annulus, is very, very short. It's in fact nearly 3 centimeters shorter, or 2.5 in majority of these patients. Moderator band can play havoc in delivery as well. So these are just 2 devices to highlight the difference. This is a Navigate. You can see a very short capsule, actually no capsule in the RV. You don't need much RV depth. So this is that patient. But on the other hand, the Intrapid device, the capsule goes forward into the RV. So there is, of course, a limitation in terms of RV depth, because if you go beyond, you're going to injure the RV and again cause a problem which you don't have. So a lot to think about when you take these devices from mitral and start putting them in tricuspid. You have to also modify your delivery system. Pacemaker leads, of course, we know that a lot of patients, at least we see, a lot of them have pacemaker, defibrillates, etc. So what have we learned? We have learned slowly that yes, you can do that. And it's not just how it sits with the device, but does it interfere with the delivery as well? Because there are times the atrial leads have a lot of loop, and they exactly come where you're going to bend your system. So again, a lot of planning is needed. And again, there are now all the devices which have been done carefully and selectively with pacing leads. And there are only anecdotal experiences of pacing lead fractures at a later stage. So we need to understand how it interacts with these kind of leads, but also with MICRA, because a lot of these patients have MICRA now in place. This is just a device parade very quickly. Navigate device was the first one with, in fact, the largest experience, but we haven't seen much movement from that. Evoke was made for mitral, but became successful in tricuspid. This has the largest experience to date in the world. Some issues with thrombosis, but I hear that it's going to get approval soon. Intrapid device, again, same, made for mitral. We have around 50 patients now or plus in tricuspid. Short profile device, but issues I showed you are the delivery system, especially with respect to the right ventricle. And Lux valve, which again has a large amount of experience in China as well as in Canada. And again, this, I think it's a generation 2 device now with RVOT fixation. And this device again is transvenous, so less invasive, and we are going to see more about this device in future. And lastly, but not the least, VDINE, which has taken into consideration a lot of physiological issues, including annular splinting, large annuli. Again, at present, I think only 12 to 13 patients experience, but we are going to hear more about these devices. And then there are some amazing concepts which always fascinate me. You're right, everything doesn't need to be like surgical valves, so these are reverse. These are so-called umbrella valves. Closing and opening is different. Whether we are going to see mainly less thrombotic issues in these patients is up for debate. So we have large annuli, large devices, but the inner valve, which is the functioning valve, ironically, has remained something between 27 to 30. And the scope of maybe increasing it is probably there, not just because of how it will work, but it will be amenable to valve-in-valve. So if you think about it, the 4 devices on the right side, we can do a valve-in-valve, but Navigate, which the biggest size actually is 54, if it fails, you are stuffed, because the only thing you can do is put another Navigate. It's just so big. So again, manufacturers are thinking in terms of lifetime management, because sometimes we are going to need it sooner than later. Lastly, but not the least, a lot of these valves which sit in SVC, IVC, the strange part is they start with compassionate use and towards the end, but these patients have lived around 5 years, some of them. So I think one can use them sooner than later. And lastly, something like a functional forma, which is the Croy valve, which is essentially a filler, but a functional filler. So I think coming very quickly to approaches, it was logical to think jugular will be easier. This is one of the first cases of Intrepid. We decided to go transatrial because we had a lot of other issues with this patient. You can see that on CT, at least it looks a very nice, clean shot, but it was still very challenging. You can go transjugular. In transjugular, we learned very quickly that when you pull the valve to get a better trajectory, you're actually pulling it up, and you need a lateral pull when you want to adjust the distance. So every time you want to come higher up, it was displacing the valve cephalad rather than in a perpendicular fashion. So again, delivery systems have to be mature in understanding, how you can deliver such a large device in a coaxial way. So finally, for logistic reasons and otherwise, I think transfemoral is still the best way to go. And I think we have seen that putting multiple curves, you can get that perpendicular pull. So to conclude, I think there are more design challenges than we think in tricuspid. I think we need lower profile devices for sure. There is, of course, an issue of conduction tissue and the pacemaker leads. And I think as we move forward, we still have other problems. And the biggest problem I think we're going to face in tricuspid is need for anticoagulation. A lot of this is a low flow valve. It opens at diastolic pressures on the right. It closes at a lower pressure as well. And as we have seen in TMVR, halt and thrombosis is a reality. So it is challenging, but it's moving forward slowly. Thank you.
So questions for Vinny, please let us know. But I want to just follow up on this last comment you made, because you've been involved with a number of TTVR devices for quite some time. What is your protocol now for anticoagulation? How long do you keep it?
So currently we recommend at least 6 months, but my feeling is it's going to be longer than that.
How about those others that are involved? How comfortable are you at stopping at 6 months? Patient's doing fine. Would you stop it at 6 months? All right.
I'm comfortable, but...
Patient is doing fine, but so you're going to keep it going as long as the patient tolerates.
95% of these people have AFib. So you actually don't.
You've already put a watchman in. You just got to keep finding stuff to do, right?
So I think the trials will eventually, someone will have courage to do a NOAC trial, right? And that's what it's missing. Again, when we say NOAC trial, I just got an email saying this patient can't afford NOAC. So I think there's a lot to go, but I think anticoagulation is going to be needed. And there has to be a bit more understanding. We have seen thrombus in Navigate, which I thought will never thrombose, is 54. And we have seen thrombus in 27 size valve as well. So it's not uncommon.
I think there's probably other things related to including flow dynamics.
Yeah.
So the other point you brought, which I think is very critical, and I think we don't give it enough justice, is what impact does tricuspid replacement, whether you're putting an oversized valve or just complete elimination, or you're fixing the base of the heart on RV function.
Yeah.
So what are your thoughts on that?
I think that's a reality because we're using devices with the stiffness which was made for mitral. But we have now other devices which are coming through with less stiffness. The issue with that will be, are we going to see stent fractures in those? So it's always, a fine balance. But I think the RV splinting is a reality. It's not just a hypothetical concept. And I think we have to just make sure that the devices which are designed, and as our oversizing has gone down, as I said, nearly 0 to 2%, I think we have less issues with that.
And this is something that Steve and I talk about with surgery. We put a ring on and we lose TAPSE. Is that important? Or is that still worth the benefit in terms of RV function? I'm curious, Hamid and Enrique, what do you guys think? Is that a concern for you? You know, we do a tricuspid. Let's say the patient only has mild TR but dilated annulus, and we're, you know, hearing now we should really be more aggressive. You guys all said that. We put a ring on, we lose TAPSE.
But if you put a semi-rigid ring or like a Memo 3D, you're not going to lose TAPSE because you see on the mitral side, with those kind of rings, you have seen dynamic motion.
I think that there's a world of difference between the valves that Vinny has shown and an annuloplasty ring that you put on the tricuspid. Yeah, you lose, but the free wall will come in, and we see that by echo that the free wall is coming. If we have operated the patient relatively in time, the free wall will still come in. But if you put the can of Coke in that base of the ventricle, that's going to be very difficult to move. And so
this is maybe a follow-up question for Joao. How important is TAPSE, you think, to RV function?
It is the main engine. It is the main engine, but once you operate, that TAPSE inevitably goes down. There are some adhesions that develop. The patient actually becomes much more dependent on the radial force, on the radial, constraint, and the TAPSE.
Even if you don't do anything to the tricuspid valve.
Even if you don't do, there's a straightforward cabbage. At times you see that not infrequently. The TAPSE tends to go down, and then you have that RV that pulls in and still works well. No, I don't think it's cardioplegia. I don't think we no. But Vinny, let's be critical. So, going back to Steve's point, you talked about are the current designs, if you have a wish list for a TTVR device, where are we missing? What would be the ideal device to suit that population?
Of course, gold standard is surgery, so I think it's easy to answer that question. No, I think you're right. I think what we are missing is, first of all, I don't know what we're missing. We're seeing these patients very late, right? So we are trying to accommodate whatever is there. But a low-profile device with less oversizing is going to work better than an oversized stiff device. That's the first learning of it. The second learning is, TAPSE or not, but RV volumes are not that generous with the current shapes of the tricuspid devices. So I think we are seeing that some of the devices which are very flexible but protrude a lot in the right ventricle, they tend to occupy a lot of volume as well. So there's going to be some volume effect. So I think my wish list is very simple that, I think these iterations, better functional diameter inside, more compliant devices, I think is going to be important. And I think devices which are more fixed on the leaflet rather than rely on annulus, I think is probably the key.
I think that's at least theoretically makes sense a lot.
Yeah.
All right. Well, thank you, Vinny. All right, second to last, we have Firas is going to talk to us about transcatheter edge-to-edge repair. So we're going to get into the debate of repair versus replacement, a long-standing debate in surgery already.
Thank you. One thing I would say, though, is I'm the one who knows the least about tricuspid valve among this panel. I did not enroll the 97% of the patients in TriLuminate like Paul. And although Joao and I started in the same institution, I was hit by lightning that slowed my development. And Steve, I tried to take the simplistic approach, man. I bought all the Algebra 2 books, all the Roman Architect. It did not help me understand the tricuspid, but I will try to do my best in addressing the challenges and the solution in tricuspid edge-to-edge repair. This is my disclosure slide. I'm going to start by a case review in a 78-year-old male, persistent atrial fibrillation, non-ischemic cardiomyopathy, by V pacing, and really improved the EF, remained symptomatic on medical therapy, and this is the TEE image that we got to deal with. You see there's a lead in the tricuspid valve, a lot of tricuspid regurgitation, and we thought that this is not adequate for to proceed with a tricuspid TEER procedure. Called Nadira, and Nadira said, well, tell Scott to use NPR, it will get better image. And we did that, and this is NPR. it really did not, get any better, and I don't think it's, I don't think we can proceed. So we pulled an ice catheter in this case, and finally we're able to to see the leaflet, and we felt really good about this case. This is a Pascal device. We're steering the device. Finally, we thought that we have a leaflet capture. It was really hard to judge on TEE whether or not we have the leaflet, and this is with ice. You can see the leaflet nice falling into the Pascal device. You can see the the ICD. We have a leaflet capture, and we closed it in septal anterior in this case. You see the pacemaker lead posterior, and we had a reasonable result on TEE. But then we said, well, there is more TR posterior. Let's just go after, and let's just go after the posterior leaflet. And now, we really cannot see the septal leaflet at all. We pull the ice catheter again, and we're able to to see the septal, kind of confident that we had a septal leaflet in the device. We close the device, and we still have significant TR. Paul told me, always be careful if you're thinking about putting a device on the anterior and posterior, because you're against the cord. In this case, we thought it was okay. All the TR is coming between the anterior and the posterior leaflet. So, and we know that we gotta get less than mild, like to see mild. So we said, well, let's just try to go after mild. It's associated with good outcomes, better outcomes. We went and we put the third Pascal device anterior posterior, and this is how the device look. I have to say, we did this on TE. There's it's a small gap, and we're able to capture the leaflet. This is how it looks on ice. You see the almost to the annulus with the device. We close, and we had trace residual TR, and we're very happy with the with the results. We looked at the use of ice or 4D ice use in the in the CLASP experience, and it's actually used quite a bit. And if you see why, the reason why ice was used is primarily for challenging anatomical consideration, and it really adds value in terms of assuring that we have leaflet capture, decreasing complication, and achieving the goal of mild TR. This is work done by but many of the TR experience. A lot of them are European colleagues, and they identify the challenges in tricuspid TR, and it's primarily around the gap. So we really have to figure out how we can reduce the gap in order for us to have ultimate outcomes in tricuspid TR. And this is where we start talking about multiple concepts, the concept of prehab, admit the patient to the hospital a couple days prior to the procedure, and try to diurese him, try to decrease the gap. Even chest compression has been tried to to decrease the distance between the leaflet. It changed the anatomy quite a bit, so we really try to avoid it. Valsalva can be helpful. Tilting the table, changing the preload, increasing the PEEP can also add value. So I think I would encourage everybody who is attempting to do tricuspid TR is to try those maneuvers, because decreasing the gap is key in making sure that you have leaflet capture and optimal results. And a lot of it can be done prior to the procedure, like diuresis, but a lot of it can be done during the procedure. Even a slug of Lasix while the patient on the table help, tilting the table, Valsalva, changing the vent setting by increasing the PEEP can help minding the gap in order to help you achieve good results. And this is a patient with or without those maneuvers, and you see how big the gap is at the baseline, on the left side of the screen, and you see by just increasing the PEEP and tilting the table a little bit, how we were able to decrease the gap in between the septal and the lateral leaflet, and able to make the a procedure relatively easier. Now, Never not listen to Paul, all right? So this is a similar case, first tier device, we got it, septal anterior, it looks good, and, septal posterior, it looks, even good. And then I just show you a case that you have anterior posterior, it's like, let's just try it one more time. Notice how the chords are a little bit different in this case than the other case that I showed you. And yet we decided to go with a third device and put it anterior posterior. And I hope this will play. We had a great result, trace residual, TR. And damn it, we stepped on fluoro for one more second. 5 minutes later, and this is what happened afterwards. We had a device SLD and a device embolization. I'm not sure if the other one is going to play. Here you go. So, device embolization, no harm done to the patient, but, the TR, went back in that spot. The device sat in the lungs, which doesn't make anybody feel good about it. But this is important if you come and address, especially if you're doing TR, especially if you're thinking about, okay, I got the septal anterior, I got the septal posterior. Do I go after anterior posterior? Think twice before you do that. So, finally, I totally agree that it's a toolbox approach for the tricuspid valve. There is no one therapy fit all. Vinny talked about replacement. Think about replacement for those patients. And also, this case, I hope, will demonstrate that if it's not only one. If you end up complication with one, there's also hope with the other. This is the patient was probably one of our first or second, TR. We put the first device in. We got a great reduction. Unfortunately, this patient ended up with a SLD and recurrent TR, and we brought this patient back and we treated this with the replacement, with the Evoke device. We were able to jail the TR device and yet got excellent results on this patient. Obviously, this was done compassionate use. So to conclude, technical success is associated with better outcome. Peri-procedural management is key to increase the chance of success. Imaging, including 4D ICE, is added value in tricuspid TR. And understanding the limitation of TR and considering other technology is also important when appropriate, including annuloplasty. And yes, Steve, as you stated, including annuloplasty again. And know when to stop. Not everyone is Paul. Thank you. I just Googled you.
It's probably better some of the other pictures you found of Paul online. All right, so Firas, how do you tell your team in the morning, let's go do a tier approach, when you showed the appeal and Vinny showed the appeal to all of us is, in 45 minutes you can replace a valve and have no TR. So which patients are you still thinking TR's the strategy I'm going to use?
Yeah. I mean, that is a question that actually we have this conversation with the patient as well. And I think there are multiple factors. I mean, yes, we talk about anticoagulation. Yes, we talk about the degree of TR reduction. But I think there is a fact that TR is safe. And, a lot of the older, frail patients, they are in the hospital for 24 hours. They go home and they feel better. And for those, this is probably all what matters. So I think that there is those subset of patients that when we talk to them in clinic about TR, we approach them with that approach. The other thing is, I really do believe that we got a little smarter in predicting who's going to do well with TR. Initially we just say, okay, we're just going to try it for this trial. If it doesn't work, we're going to try it for that trial. And if it doesn't work, we'll try it for this trial. And if it doesn't work, we'll send you somewhere else. And, we just don't do that anymore. Like, we are really getting more and more experience about what we think is better based on the gap size, the chordal structure, the anatomy, and who's going to benefit from TR. And, hardly ever right now we take somebody on and we have them leave the cath lab with more than mild TR. So that plays into that decision as well.
Do you think there will be a TR versus replacement trial in tricuspid as well? Right now, all trials are comparing
Yeah, I mean, I think you're right, Kashish. There are not going to be more trials looking into anything versus medical therapy after Triluminate. Now, whether we're going to talk about TEER versus tricuspid versus replacement, I am not sure that we will. I'm not sure that I'm not sure it's a debate. I think that there will be anatomy. There will be patients that are suitable for TEER.
To rephrase that, in your experience for us, what proportion of patients could theoretically get either approach? Because it's really a Venn diagram. So what proportion do you think could get either?
I think there is a selection bias in replacement that is selecting patients with more advanced disease. And those are the larger annuli, the tethered leaflet. That's a lot of what we're seeing. So I'm hoping that as we increase awareness and we get the patients early in the course, I'm hoping that TEER will be for those that we catch earlier in the process.
We're going to hear from David. The average cases CQ for TEER is mid-50s, but for EVOLVE and other trials, it's in the low 40s.
Yeah. Yeah. Yeah, definitely what we're choosing for replacement is more advanced disease.
Any other questions for us? I know the hour's getting late. So Richard, come talk to us about ICE. We saw some good images, and help us all learn so we could do ICE as well as you do TE.
Thank you so much. Thanks to Edwards, and thank you to Paul. I really got to say, it's an amazing time to be an imager. I mean, this is so much fun. And to have a Superman partner like Paul to work with as we figure out these things, I mean, I'm really blessed, and it's been a lot of fun, even though I joke about the pain.
Vinny says he's Superman.
Vinny is.
I've been saying that for years. He's not the kryptonite.
So I have the Avengers to work with, so it's a lot of fun. So we've heard a lot about ICE during this meeting. It's amazing. Everyone's talking about ICE, and it's really exploding. It's here to stay. It's going to get better. But where are we right now? And so rather than being redundant, just kind of showing what can we see, what can't we see at this point. So we all know that we get right in the right atrium. We can get rid of some shadowing issues with ICE. We can get views, especially grasping views when TE images are difficult. And nowadays we can have X-plane, 3D MPR, but there's an issue of cost. These are single use and several $1,000s, so that needs to be figured out. We have limited resolution in orthogonal views. These are rectangular shaped, as I'll show you. And we can't get high resolution transgastric equivalent views. So that's really important when you have multi-segmented valves. You got to really align the coaptation planes. You have small targets. I think that that's something we can't get quite yet. And there's certainly a learning curve, both for the imager and the interventionalist, to kind of figure out, with roles reversed, how to get these images. So the caveat I would say is it's not an excuse to escape learning how to image the tricuspid valve with TEE with a high level of proficiency. It's not easy, but you need to have that as a foundation, and that'll make your ICE imaging better as well. So with your typical transthoracic 3D probe, transesophageal 3D probe, you'll have a square matrix so that whatever angle you pick, you're going to get a equivalent of like a 4K high definition view. But with an ICE catheter, you have a rectangular array. So if you image along the long axis, you'll have that 4K view. But if you image on the short axis at 90 degrees, you're going to get the 480p old CRT kind of image resolution. So that is an issue. If you go up to about 60 degrees, minus 60, plus 60 degrees, you can get maybe a 720, 1080p view. So that's kind of my analogy. So it takes commitment to learn. So we decided to do ICE on all of our cases to figure out how to see things and what we can see in a more relaxed environment than just pulling it out when you're in dire straits. So this is a patient on the table. This is all from the same patient. The TE, we can see the hepatic veins, which is an important view. We get our typical TEER views, our 4-chamber view, our short axis with X-plane. We get an orthogonal view on the right, which is our grasping view at different points, anterior to posterior. We get our grasping view. We get 3D with and without color. We have a pacer lead here kind of in the commissure between the anterior and posterior leaflets. And our important transgastric short axis view. But this is a more straightforward tri-leaflet valve. tri-segmented valve with a pacer lead, just basically kind of hanging out in the middle there, not very mobile anterior to posterior. And we can put color on there too. So then with the ICE catheter coming in, we can get hepatic veins. Oops. Very nice hepatic veins with the ICE catheter. We can see the systolic reversals there. And your home view, it's naturally going to go somewhere close to that septal commissure as you come in, or your equivalent of your short axis view. And so we can do color, we can get 2D, and we can X-plane off that. But as you know, that as I told you, if you're X-planing on the short axis, the short diameter diagonal of the matrix, you're going to get poor resolution. So here you see that the image quality really drops off. You can do color Doppler, you can do continuous wave Doppler, pulse wave Doppler, and you can do 3D and multiplanar reconstruction. It's not always beautiful, but here it's very nice, and we can kind of pick where we want to grasp, put the red plane at a potential grasping plane, and then move that and make it bigger. And I like to dial up the zoom, get the Reader's Digest, large print edition image as our vision is all getting bad. And so then we go into the procedure. And so with the ICE catheter parked in the RA, tilt a little bit back, you can see the SVC here. We can see our wire going into the SVC. Here at 0 degrees, it's a little hard to see the tip of the catheter. And when you have a few bends in there, you don't, when you rotate left and right, it kind of moves you out of plane a little bit. But you have this tilt feature with the next plane. And so we just tilt it. It's in the same axis, but just tilting it left and right a little bit. And just doing something like that is very helpful. And we can see the wire coming out the tip. There's a clip coming down to the valve, and we kind of line it up like we do on TE. But again, if you have that 90-degree angle above 60 degrees, the image quality really drops off. We love it. This is a different patient. If you could just go in, it's not quite great. You just dial up to 60, and wow, you're there. But problem is sometimes this grasping view is higher than 60 degrees when you just push in the catheter without manipulations. And so when it's not 60 degrees or below, then you have to make some manipulations. So once the clip is in and you open it, we can see the gripper coming down here and line up the clip. If you have a bad grasping view, and there'll be more discussion about this, but you can go in into 3D zoom at minus 45 degrees, plus 45 degrees, and if you develop your 3D zoom off of that, these lines will correspond to minus 45 and plus 45. Then you can manipulate your ICE catheter to get the arms close to one of those lines, and then when you go back into 2D, you're going to have a closer, better picture on your X-plane. And so this is with ICE in that patient. This is with TEE. And you can see there's some shadowing on the TE, and actually the ICE image here looks quite good. You can assess insertion with ICE, and as you can do with TEE. This is all in the same patient. And assess color, residual TR, and once you release. Here you can see the clip quite nicely on ICE. You can do, this is with TEE, this is 3D, and you can see that pacer lead really nice, kind of stuck in that anterior posterior commissure. With ICE, it can be a little bit more challenging. Here we went to 2 beats. I think the better thing is go into HVR mode, but you can kind of see where the clip is and the pacer lead. And then as you come back, you can see the changes in the hepatic vein reversals. So just an example of what you can see, what you can't see. 3D ICE is a newer tool with potential utility for tricuspid TEER and also tricuspid TTVR. There's a learning curve. There's limited orthogonal resolution in your X-plane. You can't reproduce the equivalent of a high-resolution TE transgastric short-axis view, which is critical for complex anatomy, multi-segmented leaflets to line up your device. There's the cost issue, single use, several $1,000s. And I think the technology will continue to improve and eventually may replace the need for TE, but currently should be considered adjunctive to TEE. Thank you.
So that was an excellent overview, Richard. So question for you. You know, we're seeing evolution in both TE and in ICE. And if we go back to the early days of mitral TEER, how different it was compared to what it is now. It's so much more mainstream. Imaging is much better. If you could predict the future, do you think this will be still potentially both imaging modalities? Let's say 10 years down the road, technology is proven TE only or ICE only?
I think it'll get to ICE only. I think as we saw with TEE, the imaging, the processing just gets better. Now with even the TEE, some of those images we get the benefit of utilizing the graphics card in the workstation, which massages the images. And the ICE images currently with MPR do not utilize that additional processing power. So when that comes online, it'll get better. And I think the crystal rays will get better and maybe a little bit wider. So I think we'll figure it out. But it's not there yet, but it'll get there.
Next question I had was related to cost that you alluded to. How are we going to be able to recover the costs now? I mean, we've already heard about the challenges of imagers getting reimbursed during transcatheter cases. Now you're adding in a whole nother device. You're now on 2 different systems.
Yeah, I think that's going to be a challenge. Is there opportunity to do some bundling also? I mean, even if you could just re-sterilize it once, I mean, that effectively cuts the price down.
That's coming, sure.
Yeah.
I think we've heard that. All right. Other questions about ICE? How many of you are using ICE fairly routinely in tricuspid procedures? And how many of you do not? You do tricuspid procedures, but you really don't use ICE? So a few. Canadians, sorry, too costly. All right, so with that, I'm going to turn it over to Firas, who's going to end us with the last session.
Well, thank you, Gorav. That was amazing. Well, we have 2 speakers, for the end. I hope everybody enjoyed the dinner. The 2 speakers are going to be I am pretty sure are going to be the dessert and the coffee. Jason is going to be talking to us on the residual TR grade, an appropriate therapeutic goal. And I am pretty sure that after that, David is going to leave us with, like coffee, with a lot of questions that are going to keep us up all night. Jason?
Thank you. I'm hungry already for some. And they've been out of dessert for a while. I went over there, and there is none. So this is going to be your dessert. So I guess I'm the cake, and you're the frosting. Let's go. So first of all, I want to thank Edwards for supporting the evening. I want to thank Paul and the team for inviting me. And particularly, I want to thank Seibel for canceling on this talk 2 days ago and asking me to give it. So, but this is a little bit a trial design talk. And I think it'll be a nice introduction to David's talk. So the topic is residual TR grade an appropriate therapeutic goal? So, I'm a simple cardiologist, just like Steve is a simple surgeon, pressing the advance button. It's your only slide. And trying to get this to go forward. There we go. So I went to Captain Obvious to how can I start to stop? So I don't know much, but I know for sure that if we're doing an intervention to reduce TR, then we should, in fact, reduce the TR, okay? And I'm just going to sit down because that's my whole talk. But it is, yes, and very important to reduce the TR. And, we've been talking about this for 2 decades now. I remember seeing this slide, way back at the beginning of the structural heart era. People were talking about TR and this observational study from the Palo Alto VA that, more TR, as Steve said, is bad. So we know that TR is bad, even moderate TR is bad. And I thought it was interesting, Maurice, that you said that we created new grading systems, not because we had to when we saw our patients, but to match the clinical trials. And we make a lot of humor of this, but this is very important because as we're starting this field, we have to have ways to measure TR grade and see the effect of our therapy and advance our targets. Right now we're looking at reducing TR within this grading system. There's been talk about whether or not reducing someone from massive to severe makes a difference. At least observationally, it does. In this study of 13,000 patients who underwent transthoracic echo and TR evaluation, and of these patients, there were 249 that had greater than moderate TR with 1-year follow-up. And you can see that there is both a mortality and a mortality plus hospitalization difference in patients who have severe versus massive or torrential. So even reducing patients some seems to have a benefit, at least in this observational study. The other problem with trial design and the whole concept here in general is that we just have very little data in general that reducing isolated TR makes any difference. I mean, the best indication is in surgery when you're already in the heart working on something else, then you should fix the tricuspid valve. But just for isolated TR, there's very little, there's no cord lab adjudicated randomized trials that really support doing this, and therefore the greatest indication is 2A and 2B. So the other thing to consider with TR reduction is the device category. We have repair, and in repair at this point in time, we can assume there will almost always be some residual TR. With replacement, we can assume there will generally be no residual TR. And so I just kind of made 3 potential cases when we're talking about TR reduction as an endpoint or an appropriate therapy goal. How does that correlate to what we see clinically? I mean, these are all patients we see clinically. So here's a patient comes torrential, and we reduce them to severe. That's a 2-grade absolute reduction. They have moderate RV dysfunction. This patient gets readmitted in 6 weeks with volume overload. Here's a second patient underwent repair. They went from 4 conventional to 3, so they had only a 1-grade reduction. Their RV dysfunction was mild. They had no readmissions. So does that mean 1 grade is better than 2 grades? And then here's a replacement patient who went from massive to trace or 0 TR. That's a 3-grade reduction. But they had a terrible right ventricle, and they were readmitted again with right heart failure. So TR grade reduction, while very important, is not the entire picture. And this is because, as we've seen, it's very heterogeneous. There are many etiologies. We have to account for this. I'm not going to take away from Dr. Cohen's, but really, TR grade has to be paired with other goals of therapy. And this is what we saw in the TriLuminate trial and the way it was designed, that we're looking at other factors that we couple with TR reduction to determine the clinical benefit. So I just wanted to highlight the 2 kind of largest, I guess, pivotal trials that are ongoing right now here, at least, or have completed, which and look at, okay, what was the actual trial design in relation to the topic of this talk, which was TR grade reduction. So you can see that the primary clinical endpoint in the TriLuminate trial actually had nothing to say about actual TR reduction. It was all a composite of clinical endpoints. And TR grade was only mentioned as a secondary clinical endpoint. So it was change in TR from severe to moderate or less. So the goal was moderate or less. And that's it. That's the only mention of TR grade in the primary and secondary clinical endpoints in the TriLuminate clinical trial. It's kind of strange, right? Because that's why we're doing the whole procedures to reduce TR. And as we saw, TR reduction is, in fact, important, and this may be the groundwork for the next trial where we know that, okay, we really have to get it down, maybe more than we thought, to really see meaningful clinical benefit. In the TriScend trial, which is replacement, and this has been interesting, an experience in the mitral space that you would think when you're designing a pivotal trial of a replacement versus something else, that the elimination of MRTR would be paramount, which it is, but the FDA will not accept that because this is a new device class and it's assumed that there will be no TR after replacement. So we have to compare this or couple this with other endpoints, clinical endpoints. So the primary endpoint in TriScend is TR grade reduction and a composite, including, as you see here. In the secondary endpoint, there is also reduction in TR grade, but this is, again, in combination with many other clinical factors. So I would say, in conclusion, that robust TR reduction and, in fact, elimination is essential for the success of these treatments, and we should always aim to make the TR zero. The field is rapidly evolving, and TR reduction must be paired with clinically meaningful endpoints, and given the complexity of the substrate, TR reduction alone is an inadequate standalone endpoint for clinical trial design. Thank you very much.
Well, thank you, Jason. And probably it's a short session with 2 talks, and we're past time. So maybe we'll have David go, and then we'll have a few moments for some questions at the end. David, you want to talk to us about what are the compelling endpoints for practice change?
Well, thank you, Firas, and thanks, Paul, and thanks to everyone for really inviting me to this meeting. It's really been a wonderful meeting, and I've learned much more than in almost any other meeting I go to, so I think it's a great credit to the group. So I'm tasked with trying to bring some of this all together and think about compelling endpoints for therapy trials, which is now upon us and is going to be very interesting over the next year with what the FDA is looking at, what payers are looking at, all of those different things. These are my disclosures. So, TR reduction is nice, but our patients don't come to us, saying my TR is bad. They come to us because they feel poorly most of the time. And our goals are, the same things we always try to do for all of our patients, regardless of what disease it is. We want our patients to live longer, we want them to feel better, and we want them to avoid events. Those three things are really, as a physician, what we care about and what our patients care about. And, ideally, if we're a society and we have healthcare insurance, we want to do this at a reasonable cost, something that is affordable for our healthcare system or provides reasonable value. So what endpoints can we think about, and how do we organize them together? I'm going to talk briefly about traditional clinical endpoints, things that Jason already just mentioned, patient-centered outcomes, which seem to be getting very, very important suddenly, and some of the analytic approaches, but I'll try to be very brief on that because they've already been touched on in a few places. So let's just talk about the traditional endpoints, and we've learned a lot, actually, from the early trials about these endpoints. Mortality, of course, is always important. You don't have to adjudicate it. Everybody cares about it. And we thought, going into the Triluminate trial and some of the others, that because of some of the data that Dr. Sarano showed us at the beginning, that we were going to save lives with these therapies. And maybe we will, but we haven't been able to see it at all yet. And perhaps that's nature of the patients we're treating. Perhaps it's a nature of the timing of the treatment. And perhaps it's a nature of the duration of follow-up. And I do think that's an issue for the trials and something that I wish we had had a chance to redo. Cardiovascular mortality, I think, again, we like to rely on that a lot in our trials, but here I think it's more problematic, again, because a lot of these patients with tricuspid regurgitation have things, they die of things that don't look like they're the heart, like liver failure, GI bleeding, renal failure, and so, adjudicating, splitting that hair can be very, very difficult. So I don't think that's going to really pay off. I think everybody, you have to show this graph if you'd give a talk on tricuspid regurgitation. You're not allowed to give the talk if you don't. Across all the different trials, and again, Dr. Sarano did a great job of going over this at the very beginning, there's a consistent relationship between TR severity and mortality, no question, but is it causative? The statistical analyses suggest that some proportion of it is causative. But the ultimate test is whether we can treat it and fix the problem. And so far, we have 2 randomized trials that I'm aware of tricuspid valve, therapy. We have Paul's trial of Triluminate with no mortality reduction, and we have the surgical trial of adjunctive TR repair versus none with no mortality reduction. So we're 0 for 2 so far. Time will tell. But right now, we don't know if this is an achievable goal. Now, I'm on record and recorded many times showing this slide, and I naively perhaps thought that the quality of life data that we were seeing from the single-arm studies meant we were going to see a mortality benefit. And why did I think that? I made this graph on a train going on my way to TCT or to CRT or some meeting like that, where I just said, let's look at the change in the KCCQ, which goes from 0 to 100, and then the mortality hazard ratio in randomized trials, the things that we know in valvular heart disease. And so here are 3 points. These are 3 valvular heart disease trials that compared against medical therapy. One is the Partner 1B trial, TAVR, for inoperable aortic stenosis. One is the COAP trial, MitraClip for severe functional MR. And then this is the MITRA-FR trial. And if you know, it doesn't take a lot of imagination to draw a nice line connecting those and to think, well, if we can treat, if we can improve quality of life, that should correlate with something that's going to save lives. And if you look at the data from the single-arm studies, the quality of life benefit falls in this range around 10 points or so. And so you would say there should be a survival benefit. And then we do the TRILUMINATE trial, and lo and behold, this is where we are. We have a quality of life benefit is right in the range of what was expected, and we have zip on mortality, zero, nada, nothing on mortality. And the only difference I can see between these studies is everything on the dotted line is left-sided heart failure, and the thing on the right, that falls way off the line is right-sided heart failure. We'll see what more studies show us. I really am interested in the long-term follow-up. I'm a little, sad that the trials are allowing patients to cross over as early as they are, because again, I think we're never going to find out the truth about this, and that makes me depressed. For heart failure hospitalization, again, we've talked about this a bit here. It certainly is clinically important, but we know that it's sort of a much higher threshold to get a patient with right heart failure to be hospitalized, because they're not, gasping for breath. Their legs are swollen and they're, feeling crappy, but they're not, not an extremist. And so heart failure hospitalization, I think, again, while important, is not as frequent and maybe be less amenable to our therapies. So now we come to the patient-centered outcomes, and again, people call these soft outcomes. I don't call them soft outcomes. I call them what our patients care about. Your patients just don't come to you saying, I died 3 times last week and I really don't want to be dead anymore. They come to you and say, I feel like crap. And that's what most of the time we're trying to treat as physicians. We have whole therapies called angioplasty that don't do anything other than improve quality of life as far as we can tell. And we do hip replacements. And, this is a very, very important endpoint as far as I'm concerned. How do we measure it? Well, the old tried and true is the New York Heart Association class, which, nobody can even agree on. 2 people look at the same patient. They're always different. It's well established, but it's not really, first of all, patient reported. It's a physician saying, how do you think your patient is doing? The reliability is sort of all over the map, especially in unblinded trials, so not a great endpoint for our trials. What we've, again, been relying on more and more are these questionnaires, like the Kansas City Cardiomyopathy Questionnaire or the Minnesota Living with Heart Failure Questionnaire, things that are validated for patients with left-sided heart failure. They were all built for patients with low ejection fraction heart failure. They've now been extended. We've validated them in aortic stenosis. They've been validated in HOCM. They've been validated in HEF-PEF. Where they have not been validated so far, and we're working to fix that, is in tricuspid valve disease. Now, it seems to work. People, designing the original trials with tricuspid valve therapies, were, pleased enough with it. And they asked me, and I said, well, let's look at the questions. And the questions in the Kansas City Cardiomyopathy Questionnaire look like the things that your patients with tricuspid regurgitation, for the most part, complain about. So I think it's going to validate, but the work isn't quite finished yet. We're doing it. 6-minute walk test, again, does correlate with clinical outcomes, but it's not really patient-centered. The classic joke, like, who comes to you and says, I can't walk far enough in 6 minutes? That's not what people are doing. And so, it's just something that correlates with how people are feeling. And then, sort of the thing that's real sexy these days is actigraphy, because everybody's got an iPhone or an Apple Watch or things like that, and so we can get these measures, but we don't really know what to do with them and how they change yet in patients with tricuspid valve disease. And then finally, just want to talk very briefly about the analytic approaches, and again, these were touched on. Traditionally, we do a lot of trials in cardiology with composite endpoints. We're very used to composite endpoints, but they have problems. They do improve our power, but it only works if all the outcomes are on the same causal pathway, and I think as Steve alluded to earlier, it's really nice if everything lines up and goes in the same direction, then it really works. And they're easy to understand, but again, they're usually driven by the least severe component, because death doesn't usually move very much, and if the components go in opposite directions, you've got problems in interpreting them. Which is worse, how much worse, all of those different things. And so what's again come into vogue, because it gets around some of these problems but has other challenges, is this win ratio, Finkelstein-Schoenfeld, what we call an ordinal composite, which is we still have different components, because again we can't just rely on mortality. for this, but we assign rank orders. We don't have to say, like, this is 10 times more severe than that. We just have to get the order right. So it respects the ordinal nature of the endpoints. It allows, interestingly, mathematically, for combining discrete endpoints like death or hospitalizations and continuous endpoints like a health status measure or a 6-minute walk test. The challenge with them, and what we're going to start having as we are having rafts of trials that are doing these, is how do you interpret a win ratio of 1.5? And is that big? Is that small? We don't have a lot of intuition around it yet. We have to build a lot of intuition. That takes time. It really takes multiple applications. So, to summarize, and then hopefully we take a few questions, is, clearly clinical trials, we're all interested in them because they're a necessary evil to get our devices approved, to get the therapies paid for, to enable us to do things that we think will help our patients. They're rapidly evolving. The composite endpoints, whether we like them or not, are going to dominate for the next 5 to 10 years, and I think the PROs, unless we do a really long-term trial with mortality endpoints, which is probably going to take 5 years or something like that to show benefit, I think we're going to be relying a lot on PROs. Fortunately, I think the science is pretty solid there, and we're working to make that better. We have to tailor the endpoints and the timing of the endpoints to whatever their different therapeutic comparisons. And I think very importantly, and I think you should stay tuned because some of this stuff is going to be coming hopefully to a clinical trial at TCT this year, is a lot of additional research to try to validate the heart failure scales, to show that they really work in patients with tricuspid regurgitation, which has just been an assumption, to understand the magnitude of the placebo effect, right? Again, these are open label trials that right now are being driven by endpoints that to some people, are subjective. I'm not sure subjective is exactly the right word, but they are certainly something that is subject to placebo effects. And to determine whether we need other things. We have to have things that are just not being measured because they weren't really relevant in tricuspid regurgitation. And again, I would urge you guys to stay tuned. My colleague Suzanne Arnold is doing some really, really great work that I think is going to put a lot of this into perspective, and we hope to be able to present some of that at the TCT meeting this fall. Thanks.
Well, thank you. That was wonderful. Actually, go ahead, Jason.
I just have a question for David. So, this forced me to think about it. Are we overreacting to the TriLuminate trial? Do we really need to reinvent many clinical? Do we really need to? Are we overreacting to perhaps some of the recent data? Do we really need to redesign all these new clinical endpoints that are TR specific, or is it just the fact that we didn't make the TR go away? It's if we repeated the trial, use all the same endpoints, and TR was mild, and every patient who got a device would then it have been a positive trial. So, are we really overreacting here?
Well, I think we'll have another trial hopefully this fall to look at where the device, largely eliminates TR, the valve, with the TriScend 2 trial. And my understanding is there are, people are hoping to present that at TCT as well. And so that'll give us a second point on that curve, and maybe I'll be able to generate another set of, dashed lines that, that fit a couple of points. And, but it's hard not to react to TriLuminate because it was the first randomized trial in this space. And now we finally have some data to, sort of calibrate our hopes and dreams.
If I could make one comment about the mild versus moderate, it would be naive of anyone in this room to think we did not look extremely hard for some mortality signal anywhere. So in other words, if you don't think we took the patients with no TR and compared them to without no TR or mild TR versus the rest, you'd be wrong. So there is not one iota of a difference between mild, moderate, severe, massive, torrential in the trial. Now, does that mean that that's correct? I don't think so. Symptomatic severe anything should impact a patient. It's just that I think, to your point, David, the time point is probably too early. But we're going to learn a lot from class. We're going to learn a lot from TriScend because those are 2-year endpoints.
Yeah.
And if there's a signal with a 2-year, we'll know we got it wrong with TriLuminate. But it's going to be interesting to see.
Yeah, I think it's, again, we go into these trials, we know nothing, right? You were designing TriLuminate with zero.
We had
rely on.
mortality rates that were 22 to
Yeah.
50%
Yeah.
to design our trial around at 1 year.
Yeah.
22 to 50%. In 2018, everyone thought that a quarter of the patients with TR would die in a year. That
It was
was the
9%, right?
information,
It was 9.
and we were 3 times wrong.
Yeah.
So two things. One, everybody dies less in a trial than you think they're going to. They always do because you're paying attention to them. And two, as a math boy, I'm going to tell you something. The absence of proof is not the proof of absence. The absence of proof is not the proof of absence. You have to think of that every time you say. So again, I'll go to you, Paul. Would you rather have massive or no TR? You personally, right? The absence of proof is not the proof of absence.
Only one? It's like,
I think it's a bit of introspection as well. We all love devices. We all love new toys. So the problem is all the trials are designed to get a device approved. None of the trials are designed for patient benefit. So what's your challenge when you're guiding trials and in future that you're going in that way? And Firas, don't laugh about it because it's true. You all want toys. When they asked Edmund Hillary, why did you climb Everest? He said, because it's there. So we are treating TR because it's there. And Paul knows, we get referred patients 90 year plus. Now, are we really doing any benefit? I don't know the answer, but how do trials are designed which are patient-centric rather than a device win-centric? And that's, I think, the major challenge we all are facing every day.
well, I think I think about that same issue a lot. I don't think it's I think it's a very good question to ask. And I think we are always trying to balance, right? Because if the companies that are making these devices don't get some sort of financial return for them, they're not going to make these devices. So we have to balance, the getting the perfect answer, which I would always love, right? I would love to do a randomized trial where we follow these patients for 10 years, and but then we had 10 years when we weren't treating anybody while we're waiting for the answer from the 10-year trial, and so I don't think it's fair to say that we didn't design these with the patient in mind. I mean, you look at the endpoint from Triluminate, it's 3 things that patients care about. So I don't think that would be a fair comment. I think it doesn't answer every question. And for whatever reason, it definitely didn't answer the mortality question, about it. But I think it does answer the question of whether the patients benefit. It answers it at a specific time point and in a specific way. But I wouldn't say we didn't keep the patient in mind here.
Further, and the interesting thing is that when Triluminate was designed, it was actually designed such that you could not win. The intent was not to win on quality of life alone. The KCCQ bar was set at 15 points, which is a lot higher than what's needed to show symptomatic benefit. And so no one thought that the trial would win just on quality of life.
Yeah.
And it was actually feedback from the FDA that we set this bar high so that you can't win on just quality of life. You have to win on mortality and HFH or some trend in that direction. But the quality of life benefit was so much further than we thought. And that's why I think your work, David, in terms of the quality of life benefit and what that means for our patients and how we got there in terms of Joao stuff, the physiology, is going to be so important to understand.
Yeah, I mean, I think, so I think, it's always easy to look at every trial with hindsight, right? And say, like, oh my God, we should have known this. But maybe Steve knows it.
I told you guys it's going to be
Steve knows
the grand
7 things that
finale.
I don't
Maurice,
know. But I didn't know it.
In the same way that we are trying to slap to the tricuspid devices that were invented for the mitral, we're trying to slap on the tricuspid measures that were invented for something else. And if you ask me, how do I evaluate a patient for heart failure related for TR, I would look at the jugular vein, I would look at the size of the liver, the expansion of the liver, hepatojugular reflux, edema, amount of fluid in the legs. There are objective measures and not subjective. That was the traditional cardiology for the past century, has been objective measures for TR, and we're trying to do a subjective measure. Maybe it's true, maybe it's not true. I don't know what it means to have KCCQ change in the context of TR. But none of the measures of what we're assessing TR clinically are included in this trial. How do we have a measure of heart failure related really to TR
how much water do you have in your body? How do we objectively measure that? The size of the liver, the reflux, some set of objective measures that are not coming from the left side, or reduced heart failure with reduced EF, because otherwise we're not going to be able to measure the benefit to the patient with TR. It's not the same patient. We know it from, I've been doing valve disease in the last 50 years, and they are not the same. So if we apply something that is not designed for TR, we won't be able to measure the benefit associated with the treatment of TR. And so what I'm fearing is that the endpoints in Triluminate, hospitalization for heart failure, is disqualified. The first day is disqualified. That's not how they do it. So it may be a great benefit to the patient, but we did not have the right measures for these patients. And maybe the other trials, the trials that have not started yet, should give us something different as a measure, objective measure of heart failure related to TR.
Well, I mean, you measured the weight of the patients, didn't you? Yeah, I think it's, I mean, you're talking sort of, I mean, again, I mean, I would say we did measure. We measured the TR. The TR got better, so that's, you know, that's one measure. But you would like to see secondary effects of the TR, you know.
The TR, you look at an echo, you know that there is a device, and you're the core lab, and you want to please the company that has given you the core lab. So you say, oh, yeah, it's much better. And so,
Nadira, are you going to let him say that?
Can't tell there is a device there.
I think there's a lot of truth in there, and again, we are, you know, repurposing measures that were for, you know, for other purposes. I personally think, I think the fact that Triluminate showed, you know, a 12-point or 12-point difference in the KCCQ is actually very meaningful, and I don't think it's a, you know, I don't think it means that we're not measuring the right thing. We're measuring exactly what patients care about. Now, we could do better. We could make special measures for TR, and we're doing that. But the trials got faster than we can actually measure things.
Right. So, you know, we promised everybody they're going to be in bed before midnight. So, you know, I'll finish with Kashish.
I want to quote Dr. Nishmura. You know, we exercise these patients. I think a lot of patients we see for CLASP, they have shortness of breath, which we never say it's TR related. They have no left-sided disease, they have no MR, but they're short of breath. And we're treating them, they're NYHA3 in the trial. So I think what we also don't do is, and we need to do is, we need to exercise these patients like Orbita or something like that. See what their exercise capacity change, not just fluids and diuretics. I think that's where it's a very important thing, if the patient can move more.
Well, thank you all. That was a very provocative session that I, as promised you, is finished with it finished with coffee and dessert. So thank you for the audience. Thank you, Paul. Thank you, all the speaker, and thank you, Edward, for sponsoring. I'll leave that microphone with Paul, who has a half an hour finishing remark.
So don't forget the reception for all of you at Bangers. So again, don't blame me for the name. It is Bangers Sausage House. It's a 15-minute walk, or you can take one of those fancy little cart things that a sweaty guy pulls you in. You know, the thing that bikes you? Yeah, it's very cheap, only $40 per ride. But Bangers. So see you over there in a little bit. The venue is fantastic. We have a live band, and please come. Thank you.